Have you been recently diagnosed with prostate cancer and you are not sure what treatment you should choose? Have you been given multiple choices by your urologist, including surgery, radiotherapy, or just monitoring? Do you feel lost as to what are the pros and cons of each treatment and what is best for you? This video focuses on the results of one of the largest UK randomized trials called the PROTECT trial, comparing 3 different treatment options for confined prostate cancer, including surgery, radiotherapy, and active monitoring. Many urologists in the UK and worldwide use the findings of this study as a reference to advise their patients regarding which option to choose. We will go through the results of the trial and the impact of each option on the odds of dying from prostate cancer or from any other cause, so that you could be better informed when choosing what treatment option to go for. If you're ready to go through the results of the trial, let's dive in. What is the PROTECT trial? Between 1999 and 2009 in the United Kingdom, 1643 men with a diagnosis of a confined prostate cancer were enrolled in a trial to evaluate the effectiveness of different treatment options, with 545 randomly assigned to receive active monitoring. This entailed regular PSA blood tests, with further actions if there were any signs that the cancer is progressing. 553 to undergo prostatectomy, which is a surgical removal of the prostate, and 545 to undergo radiotherapy, which is radiation to eliminate cancer cells. Both surgery and radiotherapy are also called radical treatments. When was the decision for active monitoring reconsidered? If there was an increase of at least 50% in the PSA level during a 12-month period, or any concern on the part of the patient or clinician, the decision for active monitoring is reconsidered, and a review is triggered, with management options that included continued monitoring or radical treatments. What are the main results of this trial? At a median follow-up of 15 years, the results were compared with respect to death from prostate cancer, which was labeled the primary outcome, and death from any cause, metastases, disease progression, and starting hormone treatment. These were all labeled the secondary outcomes. Let's talk first about death from prostate cancer. Overall, there were 45 deaths attributed to prostate cancer over 15 years. 3.1% occurred in the active monitoring group, 2.2% occurred in the prostatectomy group, and 2.9% occurred in the radiotherapy group. There was no significant difference in the rate of death due to prostate cancer among the 3 groups. The good news was that approximately 97% of patients across the 3 groups survived prostate cancer 15 years down the line. And as a reminder, these were all cases of prostate cancer that were confined to the prostate. Let's talk about death from any cause. Death from any cause occurred in 356 men, which is around 21.7% of the entire group, and this was evenly distributed between the 3 groups. The leading causes of death were heart or lung disease in 31.8%, and other cancers in 51.6%. Secondary outcomes. Metastases or distant spread from prostate cancer. The active monitoring group had higher metastasis rates at 9.4%, compared to the prostatectomy group at 4.7% and radiotherapy group at 5%. The need to use hormone treatment. This is often used when the cancer has spread outside the prostate in the active monitoring group, or when there is evidence that it has come back in the surgery or radiotherapy group and no other salvage options are suitable. Long-term therapy with hormones was highest in the active monitoring group at 12.7%, compared to the prostatectomy group at 7.2% and radiotherapy group at 7.7%. Disease progression. There was an increase in the incidence of local progression, which means the disease advancing beyond the confines of the prostate in the active monitoring group at 25.9%, which was remarkably higher than the progression in the prostatectomy group at 10.5%, or the radiotherapy group at 11%. How many patients actually have active treatment with either surgery or radiotherapy? By 15 years, 92.5% of the radiotherapy group and 90.4% of the prostatectomy group underwent treatment, compared to 61.1% of patients in the active monitoring group. 24.4% in the active monitoring received no active treatment or hormone therapy. In other words, these patients spared themselves the side effects of surgery or radiotherapy for 15 years without dying from prostate cancer. What's even more interesting regarding these men who remained on active monitoring for 15 years without any treatment, that at the time of the initial diagnosis, 12.8% of them were considered to have intermediate or high-risk prostate cancer, and 10.5% had Gleason, grade group 2 disease or higher, which is often considered as significant cancer. Metastases or spread outside the prostate in the active monitoring group. The higher incidence of metastatic disease in the active monitoring group at 10 years was anticipated to result in higher deaths of prostate cancer at 15 years. But surprisingly, this was not the case. Among the 40 men in whom metastatic disease had been diagnosed at 10 years, the risk of death from prostate cancer was lower among those in the active monitoring group, 13.6%, than in either the prostatectomy group, 25.0%, or the radiotherapy group, 70.0%. Conclusions: the percentage of patients who survive a diagnosis of confined prostate cancer is high at around 97%, with no significant differences among how the cancer was initially treated, be it monitoring, surgery, or radiotherapy. Active monitoring carries higher risks of metastases and disease progression, but does not impact long-term survival. Radical treatments like surgery or radiotherapy reduce disease progression, but do not improve the percentage of patients who die from prostate cancer compared to active monitoring, which entails offering treatment only when there is evidence of disease progression. Active monitoring offers a less aggressive yet effective management strategy for many, while radical treatments should be reserved for cases with clear indications of higher risk. Enhanced diagnostic precision and long-term follow-up are critical to optimizing outcomes and refining treatment strategies. Therefore, a patient-centered approach, considering individual preferences and balancing treatment harms and benefits, is essential in managing localized prostate cancer.
Choosing between radiotherapy and surgery for organ-confined and locally advanced prostate cancer is a complex, deeply personal decision. It involves understanding the stage of the disease, patient health, lifestyle considerations, and potential side effects of each treatment. Both treatments have similar long-term survival outcomes, but differ in their risks, recovery time, and side effects. This video aims to provide a comprehensive, evidence-based overview of both options to help patients, caregivers, and clinicians make informed choices. We'll also incorporate data from recent studies and guidelines from reputable sources such as the National Comprehensive Cancer Network, NCCN, American Urological Association, AUA, and European Association of Urology, EAU. Organ-confined prostate cancer refers to cancer that has not spread beyond the prostate gland. It is classified into several stages. T1C. Cancer is not visible on imaging and is found incidentally on biopsy due to elevated PSA. T2. Cancer is confined within the prostate and can often be detected via digital rectal exam or imaging. T3A. Cancer is extending to the outer capsule of the prostate and may be microscopically invading it. T3B. Cancer is invading the seminal vesicles, making it locally advanced. Each of these stages can be managed with either surgery or radiotherapy, depending on individual patient factors. Once the disease extends beyond the seminal vesicles or into lymph nodes, treatment strategies may shift toward multimodal approaches. Several factors influence whether radiotherapy or surgery is more appropriate. 1. Urinary symptoms. Prostate enlargement can cause significant urinary symptoms: weak stream, urgency, frequency, and nocturia. Surgery, radical prostatectomy, can alleviate these symptoms by removing the prostate. However, post-surgical urinary incontinence is a risk. Studies show about 10% of patients experience some degree of incontinence, with approximately 1% developing severe incontinence that may require further interventions like an artificial urinary sphincter. Radiotherapy, while non-invasive, can initially worsen urinary symptoms. Patients are often started on androgen deprivation therapy, ADT, for 3 to 6 months pre-treatment to shrink the prostate and improve symptoms. In some cases, a TURP, transurethral resection of the prostate, may be performed first. 2. Patient age. Age is a critical factor. Most centers prefer radiotherapy for patients over 75, as it avoids surgical risks. For younger, healthier patients under 70 to 75, surgery is often favored for its curative potential and precise pathological staging. However, age alone isn't decisive. Overall health and life expectancy also matter. A fit 76-year-old with no comorbidities may still be a surgical candidate. 3. Performance status, evaluated on a scale of 0 to 5, where 0 is fully active and 4 is completely disabled. Surgery is typically reserved for patients with performance status 0 to 1. Radiotherapy is more suitable for patients with mild to moderate functional limitations, status 2 to 3. 4. Overall health and comorbidities. The ASA, American Society of Anesthesiologists, score helps gauge surgical risk. Class 1 represents healthy individuals, while Class 3 or 4 represents severe systemic illness, often considered high risk for surgery. Cardiovascular health is particularly important due to the impact of ADT on heart health. 5. Inflammatory bowel disease, IBD. Patients with ulcerative colitis or Crohn's disease should avoid radiotherapy, as it may trigger severe bowel inflammation. This is considered a strong contraindication to radiotherapy. 6. Previous radiotherapy. If a patient has received pelvic radiotherapy in the past, further radiation may exceed safe dosage limits and lead to complications such as bowel damage, urinary strictures, or fistulas. 7. Cancer stage and extent. For T1 to T3A, both treatments are generally effective. For T3B, radiotherapy is often favored because it can target both the prostate and seminal vesicles more comprehensively. In T3B cases, surgery may still be used as part of a multimodal strategy, followed by adjuvant radiotherapy based on pathology. For example, if there are positive margins or extracapsular extensions. Advantages of surgery. Radical prostatectomy. 1. One-time treatment. Typically involves a 1 to 2 day hospital stay, followed by recovery at home. Most patients do not require hormone therapy unless the cancer is aggressive. 2. Precise diagnosis. Allows complete pathological analysis of the prostate to confirm grade and stage. This helps guide decisions on whether further treatment is needed. 3. Salvage options. If cancer recurs, salvage radiotherapy can be effectively applied to the prostate bed. This is harder to do the other way around due to post-radiotherapy scarring. Disadvantages of surgery. 1. Surgical risks. Risks include infection, bleeding, rectal injury, 1% incidence and anesthetic complications. 2. Incontinence and erectile dysfunction. Postoperative incontinence affects 10% of men. 1% may experience severe leakage. Erectile dysfunction rates range from 30 to 60% depending on age and nerve-sparing technique used. Advantages of radiotherapy. 1. Non-invasive. Avoids surgical risks and recovery. Performed on an outpatient basis. 2. Lower incontinence rates. Only about 1% of patients report urinary incontinence post-radiotherapy. 3. Better for older or less fit patients. Especially beneficial for those with comorbidities or limited life expectancy. Disadvantages of radiotherapy. 1. Longer duration. Standard treatment is 20 to 39 sessions over 4 to 8 weeks. Shorter, hypofractionated schedules are emerging. 2. Requires hormone therapy, ADT. Is often started 3 months prior and continued up to 2 years for high-risk cases. Side effects include hot flashes, fatigue, weight gain, loss of libido, mood swings, increased risk of osteoporosis and cardiovascular events. 3. Salvage surgery is challenging. Post-radiotherapy tissue fibrosis makes salvage surgery more complex and risky. According to a 2023 SEER database review, the 5-year cancer-specific survival for localized prostate cancer exceeds 98% regardless of treatment modality. The PROTECT trial, Hamdi et al., NEJM 2016, found no significant difference in prostate cancer-specific mortality at 10 years between surgery, radiotherapy, and active monitoring. Recurrence occurs in 10 to 15% of patients after either surgery or radiotherapy. Ultimately, treatment decisions should be individualized, ideally through a multidisciplinary team, MDT, involving urologists, radiation oncologists, and medical oncologists. Tools like the Capra score, Gleason grade group, PSA level, and MRI findings should guide risk stratification and treatment planning. Conclusion: both radiotherapy and surgery offer excellent cancer control for organ-confined and locally advanced prostate cancer. Your choice depends on your age, overall health, urinary symptoms, cancer stage, and personal preferences. Always discuss your options with your care team. Ask about side effects, and consider a second opinion if needed. With the right information and support, you can make a confident, informed decision about your prostate cancer treatment.